so much. Can all of you join me in thanking Professor Ashley for that fantastic talk? And so we will be moving on to our next talk, which is a plenary lecture. And I'd like to invite Professor Lynn Madden to the stage to give us a talk on unpacking the implementation tools for NIATIC's A Comprehensive Implementation Strategy. So I'd just like to give a brief introduction of Assistant Professor Lynn. She's from Yale School of Medicine AIDS program and a faculty member in addiction medicine. She's also the CEO of the APT Foundation, a non-profit agency founded by members of the Yale University Department of Psychiatry to promote health and recovery for those who live with substance use disorders and/or mental illness. Her interests focus on identifying treatment gaps in substance abuse or mental health treatment and improving access to those services, including services for persons who are incarcerated or recently released from jail or prison. She also does large and small-scale implementation projects that are focused on access and quality in mental health care and substance abuse treatment. So let's welcome to the stage Professor Lynn Madden.
Good morning, everyone. It's a pleasure to look out and see all of you again today. And I want to just take a moment to thank the folks who organized this boot camp. I am very pleased to be here and just want to acknowledge that this is a process of people learning together. And yesterday, I think, was very energizing. So hopefully I can keep that up today. One of the challenges is I've been here 48 hours and I've slept about 4 of them. So hopefully I will be cogent. If not, just kind of like start waving your hands or whatever, and I'll try to back up a little bit. So I have the pleasure of talking with you about the NIATEX model. NIATEX is a comprehensive set of tools that bundled together form an implementation strategy. I will try and do what Dr. Esserman did yesterday, which is race through something that really could take a long time to talk about. And she did that with her talk on methodological considerations very well. So I have big shoes to fill here this morning, but let's get moving. So NIATEX was originally a partnership of 2 grant programs in 2003 in the United States. And those 2 grant programs were, one of them was funded by the United States federal government, with the Substance Abuse and Mental Health Services Administration, and the other, which I was fortunate enough to receive one of these grants along with Dr. Farnham at the hospital that I was then running, was funded by the Robert Wood Johnson Foundation. So what's important about this? This is government money coming together with the money from a private philanthropic organization, which at that time was essentially unheard of, particularly in relationship to try to advance the field of addiction treatment. So NIATEX as a word stands for the Network for the Improvement of Addiction Treatment, at least initially. And it was formatted on the work of the Washington Circle Group, which I'll talk about in a moment. But NIATEX has been extensively deployed in the United States over that 20-year time period. And I have been fortunate. I was a grant recipient in 2003, and then in 2004, and this applies as well to Dr. Farnham, I became a coach for NIATEX. So they immediately did some of the things that Dr. Hageman was just talking about, really pressing people into service, training them, and deploying them across the United States at that time to try to advance the field of addiction treatment. So we have I'm actually going to do this so I can see the slide deck. We've more recently applied some of these techniques in carceral settings. We're currently in the evaluation phase of a giant J-COIN study in which 55 jails across the United States, and J-COIN is the Justice Community Opioid Innovation Network. in which 55 jails in the U.S. were recruited regarding efforts to increase medicines for opioid use disorder. That's Todd Molfenter, who currently is the executive director at the NIATEX Foundation, and Faye Taxman, who Dr. Altice has also worked with fairly extensively, and maybe some of others of you in the room. As well as a HRSA-funded Strengthening Systems of Care grant that's just wrapping up. Dr. Altice was the PI there. I was one of the co-investigators, intended to improve OUD care for those living with HIV and vice versa. So there's a lot of, you'll see from the kind of lineage of NIATEX that it still all hangs together. You'll hear some of the things you heard yesterday morning from Dr. Davis. So international deployment includes extensive work in Ukraine since 2014, and I think Rick is going to talk a bit more about that later today, as a framework for scaling up medicines for opioid use disorder for the purpose of preventing HIV. So treatment as prevention that Dr. Ramon spoke about yesterday, this was one of a key way that we actually employed and deployed NIATEX. So we were trying to prevent HIV and improve the HIV cascade everywhere along the way. There is some really great work coming out of that collaborative and out of that particular grant, and again, we'll highlight some of that later. And we have a newly funded R01 for essentially the same purpose in Central Asia. That includes Tajikistan, Kyrgyzstan, and Kazakhstan. So you can see that this has been deployed across various kinds of healthcare specialties with various reasons, and very readily deployed in lower resourced settings.
You could just have the new Peru grant that just came in a couple days ago.
Oh, the new Peru grant that just came in a couple days ago, yes. It's also employing NIATEX. That is also an R01. Where we will be working to decentralize HIV care across Peru. Most people who have HIV in Peru are treated centrally in the city in very large clinics, and they have major adherence issues. So we will be deploying a learning collaborative and a number of other of the NIATEX tools. So again, what I want to stress is NIATEX is a toolkit. Right? It's not an implementation framework, it's an implementation toolkit, and it can be mapped onto any implementation framework, and it has been. Right? So that's a really interesting way of, I think, of thinking about NIATEX. So the No-Do Gap, this is a book that came out in 2020, so here we are, we're still talking about this, that it takes at least 2 decades to really, for science to get into practice. And the Washington Circle Group, which was meeting at that time in 2020, they had a look at this group. They also the Washington Circle Group included members such as Dr. David Gustafson, who is the founder of NIATEX. Don Berwick and Dave Gustafson have a long relationship going back many, many years. They together worked on establishing the Institute for Healthcare Improvement, which created this essential learning collaborative model. So this is a huge piece of what NIATEX became. The Learning Collaborative, this comes out of IHI in 2003, the same year that NIATEX was formed. So what you have are people coming from various different places, all trying to figure out how to work on this implementation gap, this science to practice gap. The Washington Circle Group is well known because it was primarily focused on trying to simplify what seemed like a complex set of issues related to the provision of substance use treatment. Right, so there is a giant gap in the substance use treatment world in the US and in many other healthcare specialties as well. But this one, they were focused on the gap in the addiction treatment cascade, if you will. And they were really employing a systems thinking orientation. This comes from the work of Dr. Edwards Deming. Dr. Gustafson, again, founder of NIATEX, studied with Edwards Deming. So this doesn't have a lot of antecedents, right? When you think about where does implementation science come from, again, we heard from Luke yesterday, some of the background and history there. We're like a single generation into trying to figure out how to make this work, how to make what we learn become more readily available to people who need it, right? So we're not a long way into that, and what that means is it's kind of an exciting time to be thinking about implementation science. You know, I find it very energizing. But a systems thinking organization is simply this: everyone is acting as they should, given the system that they're actually in, right? And what's important about systems is we make them up. We make them up, and they derive from culture, they derive from regulatory constraints, they derive from what are considered public needs, but we make them up. And what that means is we can change them. But your current system, Edward Demings is an engineer, your current system is perfectly designed to produce the results it's currently producing, right? We get what we get because this is how we do it. It's really straightforward. You heard Dr. Rahman refer to that yesterday, right? What's important is you have to figure out why we're not getting what we want. What is it about the system that we could shift potentially in order to get something different? So to produce different results, you must change the system. And that seems like a daunting task, right? Sometimes we think about, oh, you know, how are we possibly going to do that? So that was, again, this kind of brilliance of the Washington Circle Group, which evolved into NIATEX, is they decided to try and simplify that so that people didn't need theory about implementation science. What they needed were tools to implement already proven evidence-based approaches. So NIATEX tools were developed by engineers and social scientists. So again, that Venn diagram that we saw yesterday from Luke, I mean, that's perfect. It really belongs in this talk. I might have to grab that and put it in here. But they were primarily psychologists and public policy persons who made up the people who sat around in rooms with engineers and tried to create this toolkit, which is what engineers are really good at. Right, so when you see things like checklists and matrices and some of the things we just heard in our previous speaker talk about, these are essential engineering tools. They were trying to short circuit that dreaded 17-year evidence to practice gap. Right, so led by Dr. Gustafson, who's now Professor Emeritus at the University of Wisconsin-Madison. He is the key architect. He is a personal friend of mine. And a mentor. He still is active on the NIATEX Foundation board. So every now and then, one of us will get a call from him and say, what do you think about this? He'll say, well, why can't we do that? Right? So he's very good at this appreciative inquiry set of ideas. He also is the founder of CHESS, which is the Center for Healthcare Enhancement System Studies at the University of Wisconsin-Madison. They've done some really interesting work on loneliness, asthma, breast cancer, right? So these tools have been applied in a whole variety of ways to public health issues that sometimes seem intractable. So why process model? These folks primarily focused on process, right? And they said, well, process model is important because people or customers are served by processes. And I won't belabor this point, although if we have a chance to talk more, we may talk more about this. We do not treat people in healthcare as customers. Right? Customers are people who choose things. They go somewhere to a store or online and they know what it is that they have for resources and what they might want as attributes in a particular, quote, product. In healthcare, we primarily are telling people what they need. Right? That's a very different framework. Right? So if we really, and when we talk about chronic disease management, which addictive disorders are, which Dr. Rahman made the point yesterday, HIV is becoming more like the management of a chronic disease, treatment of HIV, right? What do we do in chronic disease management? We center the person with the illness, and we teach that person when to touch the healthcare system. But if you, for example, if you happen to have diabetes, you're living with diabetes, you know what to do if your blood sugar gets to certain levels, high or low, because the healthcare system and the people around you teach you how to do that, right? That's a customer-oriented process. The other thing about customers that's important to keep in mind, I think, is sometimes they don't want what we have to sell. So in healthcare, we don't understand supply and demand at all. We don't understand it at all. What we talk about are gaps, the number of people who have a particular condition and the number of people who ought to be treated for that condition. We call that the treatment gap. Well, some of those people might not want treatment, or they don't want the kind of treatment that we happen to be offering, right? That's demand. So supply and demand are kind of messed up in the healthcare universe, and that's, again, a real opportunity for thinking differently about how we attract people to the services that we need them to want to use so that we can improve the population level health outcomes. So process models are really helpful. The other thing that they're really helpful in reinforcing is that there are no bad people. We're not looking at a system to find bad people. Right? We're looking at a system to see if there are processes that we can improve, that can move us in the direction that we want to be moving in. So that's the fundamental consideration here. We, in fact, assume good intentions. Everyone is doing the best they can, given the system that they're actually in. People in healthcare, by and large, work really, really hard. Many people in healthcare work more than really, really hard. They work all of the time, right? They're doing work all of the time. So we assume good intentions. People are doing the absolute best that they can, given the system that they're in. So one of the things that NIATEX brought to the table, so across the United States, ultimately there were hundreds of healthcare organizations, now numbering in the thousands, that actually became members of various NIATEX collaboratives, is they set out aims, right, or goals for these organizations. So one of the big problems in implementation science is that it generally speaking takes experts who have to come in and teach you to do things, and there's a knowledge transfer. They said, okay, we've boiled down everything we know about addiction treatment, and this again begins to apply to lots of other kinds of healthcare as well. If you can do one of these four things, right? Let's figure out how to do one of these four things. Pick one of these as an aim. So each organization, each working team gets to choose one of these aims. We call them simple aims, and that's in quotation marks because they're not at all simple. But again, that becomes the beauty of this approach, right? Reduce wait time anywhere along the way. If you call or walk into a healthcare organization and you were told that you need to come back in 3 weeks or 3 months, what do? Right? I mean, the message there is very clear. Whatever is going on with you is not important. Right? So there's a meta message happening there. Wait time has a psychological detriment on people seeking services, and it also ultimately has a clinical detriment as well. You want to reduce no-shows. Making appointments is inherently inefficient. If I give you an appointment for a month from now, first and foremost, you have to remember to come. Right? I give you when it comes to addiction treatment, 50% of people who are given appointments out into space at some point when don't show up. 50%. So that is a lost opportunity for both the healthcare organization and the person. And it represents, if you think about this as an engineer might, it represents unused capacity. We have capacity in the healthcare system, perhaps, in most pieces of the healthcare system that we don't actually use because we haven't organized ourselves as efficiently as we could around what people actually can and will do in terms of getting their own health care. We want to increase continuation. Disease management always goes better if you can keep seeing the person over time. And we want to increase the number of admissions because the treatment gap is huge. Right, so along with that, we have 5 key principles, which are evidence-based predictors of change. First and foremost, this comes from a factor analysis that is related to what Luke spoke about yesterday, some work that was happening in the British National Health Service to reduce wait time, particularly, right? There was big scandals happening back in the day. People couldn't get into care. Dr. Gustafson was part of a team that also included a key person, a nurse named Lynn Mahar, and they published evidence-based predictors of change after doing factor analysis of the existing literature. First and foremost, and this is important, understand and involve the customer. Focus on key problems, select the right change agent, seek ideas from outside the field and outside the organization, and do rapid cycle testing, and I'll talk a bit about these. But interestingly, in this factor analysis, the idea of understanding and involving the customer outweighs the other 4 added together. So back to my point about the fact that customers are really not the way we think about the people who receive healthcare services. Also fundamental to Niantex is the idea of co-production of knowledge. Some questions that came up during the last lecture were really getting at some of this. Co-production of knowledge, the principles of this are knowledge that's developed, in this case by a change team and coaches, as context-based, pluralistic, goal-oriented, and interactive. This assumes that it's not about experts speaking to people who don't know things, but rather experts learning from people who potentially need to do these services or receive these services, and vice versa, right? So that there's a kind of leveling of gathering of knowledge that informs everyone in that stakeholder group. The 4 elements of working with co-production, which inform the Niantex tools: equality, diversity, accessibility, and reciprocity. Right, so this is all about open source information gathering, freely sharing with others, and people teaching each other. So the Niantex toolkit, which we had the great good fortune of unpacking nominal group technique yesterday. There is the opportunity to have a conversation about coaching and facilitation tomorrow. So I'm not going to spend a lot of time on this. It was back to Dr. Esselman, like, I don't know how we could do that. But the Niantex toolkit, the most important thing here is to set an aim. You don't know what you're doing when you're trying to make improvements or changes if you haven't set an aim. Be better is not an aim. Right? Soon is not a time. Right? Some is not a number. Right? These are goals and value statements, but they're not measurable. So we want to set a measurable aim, and you need to add coaching and facilitation. So one of the things we saw yesterday was that external facilitation was actually a driver in a successful implementation project. You just need an exoskeleton. That's how I think about facilitation. People are really busy. On a change team, which you form at the local level, we want an executive sponsor, in other words, someone who gives permission to the team to actually make changes, a change leader, and a data manager. You do not want an epidemiologist for your data manager. We're going to be looking at small, daily data. How many times did the phone get answered? Right? How many people left a message? So small ideas so we can see if we can change processes. There are plenty of epidemiologists involved at a higher level looking at how the work ultimately changes the field, but you don't need that at the local level. Remember, this is designed to be really simple for the people using it. Rapid cycle PDSAs, these are changes that need to be doable in 2 to 4 weeks. 2 to 4 weeks. If you can't figure out if your change is moving you in the direction you want to be moving in 2 to 4 weeks, you need to shrink the change. Just make it little, right? It's an iterative process. Answering the phone is something that you can focus on in real time, and it can have a measurable impact down the road. All data is useful. There's no bad data. Right, so that's the other thing that's often difficult for people to internalize, right? Because everybody's kind of in healthcare field, type A people, we want to do a good job. Researchers are like, I want this to show that it really went well. Not going well is just as useful as going well. And again, we heard that from Dr. Vermine yesterday morning, right? Not everything works. If we knew what worked, we'd be doing it already. But that shouldn't keep us from trying to actually do things. So one of the things that's beautiful about rapid cycle PDSAs is that it's really reinforcing in real time. The other thing that's nice is you can fail really fast, right? You're not 24 months into something or 6 years into something when you actually fail. You can figure out very quickly that something's not working and you can change that. right? A change must be doable, as I said, in 2 to 4 weeks. So PDSAs, or Plan, Do, Study, Act cycles, are informed by the following tools. So we have aim setting and coaching as key NIATEX tools, right? We have change teams that get sponsored at the local level with these 3 roles, and then we use rapid cycle PDSAs. Those PDSAs are guided by the walkthrough, which we'll talk a little bit about, but the walkthrough is an attempt to really try and understand what experience the customer is actually having. They're informed by nominal group technique. You can gather a lot of information in a really short amount of time, right? And that gives you some idea about what people are thinking. Flow charting, which I was talking to Sheila Shinoy the other day. I think in flow charts, personally. I think that's kind of scary, but I do. I mean, I think about, like, where are these decision points and how are people navigating this, and what is it that how could that pathway look a little bit different, right? So flow charting can be really useful. One of the things I like about flow charting is that you can compare your desired flow, your desired workflow, to your current state. And that can give you a really good idea about one thing that you might like to change your process, right? Simple pre-post metrics. Are you moving in the direction you want to be moving in? All of the really good statisticians in the room, cover your ears. But the question that we have is a simple yes or no data question. When you make a process change, are you moving in the direction you want to be moving in? Yes or no? Right? It may not be significant. We'll learn that over time, whether it is or not, but it's a way of evaluating those change cycles in a room with people in real time. Right? Ultimately, we'll learn if those are significant changes. And then a project charter form. So that's the toolkit in a nutshell. NIATEX coaching and facilitation, which we're going to unpack a little bit tomorrow morning. It happens in 3 not necessarily linear phases. I was really excited to hear Ashley talking about loops, right? I mean, processes that go off into space when you just tell people to do something, and that's kind of a linear approach. We don't know if they're working or not, and we don't often have ways of evaluating them. But NIATEX coaching happens in three basic buckets. First and foremost, it's about building relationships. So again, go back to those social psychologists that were part of forming this toolkit. What they brought to the table to a very large degree is that relationships power change teams. So people build cohesion and collaboration when they're working together on a particular project, and that's particularly true when you can see your results in real time, because that's very motivating, right? And one of the roles of the coach there is to remind people that all data is good data. Oh, it didn't work. How cool that you tried that, right? What do we know about why that didn't work? But what else might be tried, right? So that becomes part of the coaching role. Building capacity. I think Rick is going to talk about this a little bit as well, but what has happened in many settings where NIATEX has been extensively deployed is they don't need us anymore. So you build capacity, which also builds sustainability. There were big floods in the state of Vermont, in the United States this past week, huge floods and mudslides, and I happen to have been working with them since 2017 on a variety of projects organized around HIV and drug use disorders, and I called them. I said, is everyone okay? They said, well, this woman I spoke with, Stephanie Beck is her name, she said, yeah, they're great. I called everyone and they said, oh, we got this. We've been working together for the last 6 years. We know each other. We're doing fine. Thanks for calling, right? So you can build capacity among groups of people who have like-minded goals, who don't have other ways of actually coming together. And in lower resource settings, this is vital. Right? You need to be able to go away. You have to take your intervention and go away, and they need to be able to sustain the work that's actually happening there, right? So build relationships, build capacity, and building sustainability. So conducting a rapid cycle change. Okay, Denise, I have much more sympathy for you today. There we go. Conducting a rapid cycle change exercise, PDSA. Everybody has seen this, right, in a whole variety of settings, particularly around quality improvement. This is an implementation tool. What are you trying to implement? The innovation here is that this needs to be doable in 2 to 4 weeks. I would also remind everyone that there is no 100% solution. They simply don't exist. Right? So what you're going to do is multiple PDSAs over time that are iterative. They build on one another. And again, part of this is where sometimes rigid clinical protocols can be difficult to implement because we put a lot of information in clinical protocols and a lot of steps in clinical protocols. And that is hard for people to start with that complex process. What's easier, potentially, is to create small changes in protocols in a sequential way, or small changes in processes in a sequential way that are moving you in the direction that you want to be moving in. Right? So changes that result in improvement, you keep. So plan the change, do the plan, study the results, and act on the new knowledge. Act is the important part and the tricky part, because sometimes we want what we're doing to be the answer, and it just isn't. Right? So when you look at the data that we have, what you need to do is act on that data by adapting the change, which is the most common thing that happens. Change the change a little, right? Adopting the change because it really did work, or abandoning the change because it doesn't work at all. And again, that's difficult to do. Abandoning a change is difficult to do if you spent 3 years planning it. Right? There's a lot of investment in that. So when you're thinking about rapid cycle change and you're just trying stuff that the group has come up with that might move you in the direction you want to go in, that data comes back to that change team. If it doesn't work, everyone can see that, and you say, okay, we're not doing that anymore. What's next? So when we did nominal group technique yesterday, what we developed is a list of potential ideas and priorities that the people in the room believe to be accurate, right? But they might not be. They may be accurate. You can test all of those, right? So that's the beauty of really sticking to the PDSA. When you do a rapid cycle test, you need to ask yourself, what are we trying to accomplish? How will you know if a change is an improvement? And what changes can we test? Very basic. So conducting a walkthrough, you want to play the role of a client and a client family member. This is a NIATX tool that helps you gather baseline data. Just walk through the process. So you're experts, or you know experts in the particular area you're trying to work on. Come up with a scenario, call the place if that's how you normally get there. Walk through the front door, that's how you normally get there. See what actually happens, right? So try to think and feel as the client or family member would. Think about what they might want changed. Ask the staff what changes that might make process better for themselves and for the clients. And then compile a list of needs and possible improvements that can address these needs. Now, when we do walkthroughs, generally speaking, we tell people that we're going to do that. This is not secret shopper, right? So what you want to do, again, back to co-production of knowledge, is you want to work together. People will be on their absolute best when you do a walkthrough. There will still be opportunities for improvement. So they're going to be able to showcase for you how they do their job well, how they do their work well, but you still will come up with observations and ideas, and so will they, that might help improve that process. Nominal group technique, an important tool that we spoke about again yesterday, but one of the benefits of NIATX is that it is a way to involve staff, improve morale, and move toward creating new opportunities. We see change as a regular and ongoing element of work. No system is actually static, right? Systems are not static. And if we can't help ourselves figure out what's next all the time, then the world moves on from the system that we created. So it's never finished. There's always a possibility for shrinking that gap. And this nominal group technique and the walkthrough are really great ways of collecting baseline data. So breakthrough innovations in Niantex, before I move to 2 case examples, issues are complicated. You know, sometimes I've been in meetings where I've been taking notes about in the same group of people for like 3 years. And we haven't, because it's an issue or problem that we all care about, but we really haven't moved along very well, right? I mean, so there's a lot of goodwill and good energy in the room or among the group members, but there isn't much progress because issues can be very complicated. So aim setting can help break through that. When you set an aim, it is with the full knowledge that the aim itself is not necessarily the answer. It's a piece of the pathway to close that gap or to implement whatever that practice actually is, right? But it allows people, if you can set an aim in real time and focus on the aim, it allows people to see if they're moving closer to that aim, which is motivating and good for patient care, right? So aim setting is really, really helpful. Rapid cycle change appeals to both logic and emotion, which is important. It can be hard to sustain energy around a group that's meeting for a very long time. Implementation is guided with simple approaches that emphasize coaching and relationship building. Teams gain implementation and performance improvement capacity by working together, using these tools that are designed to help them be successful and to help them see how they're actually doing. The walkthrough is an innovation of Niantex, an opening experience. I have to tell you that when I first started doing walkthroughs, I was already running a large healthcare organization, and I thought to myself, I know what's happening for patients. You know, I work here. I mean, I wrote some of these policies. Why do I have to do a walkthrough? And it turns out that I was 100% inaccurate. I had no idea what people were actually experiencing, right? And until you ask them or try and have that experience, I would suggest that you don't either. Right, so a walkthrough is a really interesting thing to do. It doesn't take a lot of time. We do them all the time now at various stages along the way. You know, what do follow-up appointments look like? Who tells you when you have an appointment? So there's a lot of things that you can walk through in the healthcare setting. And then business case or clinical advantage. So changes need to be tied to a strategic advantage in real time, not to some theoretical advantage down the road, right? So the advantage is tied to population level health outcomes, which can be on an individual person basis. So if you're working in a small clinic and you have 100 patients in this clinic and you have, you know, a 25% no-show rate and you try and work on that no-show rate and you make an improvement, that's an advantage to the organization and to the individual. And ultimately, those to the field itself, if we can gather that kind of knowledge. So starting a change project, really straightforward. Set an aim, select a change team, name a change leader, an executive sponsor, and a data person. Conduct a walkthrough, right? You can do this in a department, you can do this in an organization. The trick is to keep it simple, collect baseline data, review the data and the walkthrough, and then suggest a process change that might move toward the desired aim. So that's, in a nutshell, is the approach that Niantex takes. And I have about 13 minutes, so I want to race through a couple of case examples and leave a few minutes for some questions. This is, there are so many examples. And a lot of work has come out of the Niantex team. There are many publications. There's a whole variety of complexity that you can take a look at. I selected a couple of examples that I know pretty well. Small changes can really matter. So this one is from the Rhode Island Department of Corrections. Rhode Island is a small state, very small state in the United States on the East Coast that had and still does have a big problem with overdose death from opioids, right? So what did they decide to do? First and foremost, they set an aim. They wanted to reduce deaths among people who were leaving incarceration. Right, so that was their aim, reducing overdose death among people leaving incarceration. The way that that is measured is that a person is considered to be leaving incarceration for 30 days. So if somebody dies in that first 30 days from overdose, that is counted, as you will, as a Department of Corrections death. Okay, so they wanted to reduce deaths. They made 4 changes. They made them sequentially, just like that little model that I showed you a minute ago. Little PDSA cycles moving along up the incline, right? The first thing they did was to continue everyone who was entering incarceration on any existing medicine for opioid use disorder that they were already taking. Right? Now that seems simple, and they already have a system for managing other chronic illnesses in that setting, right? People come in on antihypertensives or that sort of thing. They're continued while they're incarcerated. But it wasn't so simple because the people delivering the intervention didn't necessarily know how to do it. So there was a little bit of a backstory here, and the reason they selected simply continuing people on medicine is they didn't have to make the diagnosis. It had already been made. Right, so they're just doing what is already normal practice in the setting, continuing the medication for opioid use disorder. Change number 1, right? So you can see how you can break up this approach so that you don't go from 0 to 180 immediately, right? What you're looking at, change number 2, okay, they did this, okay, that was relatively successful. It doesn't mean that everybody in the setting who had opioid use disorder was necessarily being treated or diagnosed, right? So what did they decide to do? They decided to screen everyone using a single item question screener developed by Sarah Wakeman and others to screen everyone for opioid use disorder. Right? That's not treatment, that's screening. But when you do screening, you get an idea of the extent of the universe, like how many people actually need to be treated. Right? So this is a process change. They're already screening people at the front door for all kinds of things. What they decide to do is they're going to add this single item question screener and diagnose opioid use disorder if it's present. Change number 3, so that now they have baseline data. They know how many people are coming in who are on a medicine for opioid use disorder. They know how many people screen positive, right? So they understand their universe a little bit better than they did before. Now they're going to offer the people who screen positive induction to MOUD as indicated. Right? So again, this is a big step, but they took this step. Now we're about 9 months into this process. They took this step after learning to use these medications in the setting, after screening all the people for opioid use disorder. And then their 4th change was active discharge planning, which does not happen in carceral settings anywhere in the world very readily. Right? So active discharge planning. Where's the person going next? Right? They brought in members of community agencies. This is not easy work, but they made a change in their discharge from the facility by bringing in people from the community earlier than release was planned and introducing them to the person who they had inducted on a medicine for opioid use disorder. So really sequential. You can see again, if they had started out having all of these things as their initial goal, that would have been a much different kind of approach than taking, one bite of the apple at a time. So what's the outcome? Once they implemented all 4 of these changes, they reduced post-incarceration overdose death in Rhode Island by 63% in a single year. Right, this is Tracy Green and colleagues. This has been published. So initial evaluations that included explicit questions regarding OUD and warm handoffs post-incarceration were key components in this approach. These are promising practices. This is the other thing that Ashley was just talking about, right, is really pulling out of what you see ideas that could potentially be disseminated or diffused into the universe. What's really happening here? So a couple of key things that were happening pulled out by coaching primarily. All right, now moving to a second case example. Again, I'm going to go through this quickly. This is from the APT Foundation, where I work. APT is an organization that serves people with substance use disorders and mental health needs. When I arrived there in 2006, access to treatment was relatively limited, retention and care was not good, and the organization was really suffering financially. Right? So we had a number of issues. What we tried to do is choose an aim. The aim that we selected based on the literature and based on our prior work in NIATEX, we selected one of those 4 aims, right? This is only 3 years post NIATEX, was wait time. Wait time is endorsed by the literature, in the literature as a key reason that people don't enter substance use treatment. Methods proven to increase access to care are informed by identifying and eliminating barriers, like using nominal group technique or flow charting or the walkthrough. This is how you identify these barriers, right? And we systematically decided to eliminate these barriers. This was not a research project. This was active change or implementation of evidence-based approaches inside an existing organization. Right? And you can find organizations, again, all over the place who are doing this sort of thing. We also theorize that retention is improved by shifting programs in ways that reduce program-level demand on patients. And we don't have enough time to talk about that a lot, but we ask a lot of people using the healthcare system. Right? We want them to come in, we want them to bring certain pieces of paper, we want them to come on time, we want them to go to the pharmacy to pick up their medication, we want them to call our offices, leave messages if they need medication refills, we want them to do that several days in advance. Most of that is for the convenience of the healthcare system and not necessarily for the convenience of the person receiving services, right? So there's a lot of ways of thinking about what are the program level demands on the individual receiving care. So here's the situation that we had there in 2006. Waiting time to treatment was just under 22 days. This is after we had already met a person. Right? So they're waiting 22 days after we met them before they receive medication. I don't even know how long they waited to get that first appointment because that data was not collected. So we made a series of changes over time. And by June of 2007, we reduced that to just over a week. By June of 2008, we were down to 2 days. And by June of 2009, 10, we were doing same-day admissions, right? So you might ask, how did we do that? With a series of process-level changes that were introduced over this 2-year time period. We formed a change team, very basic. Walkthroughs were conducted. NGTs were performed with all staff across the organization, really decided to ask that question, why do people wait, what can we do about that? Initial changes included some promising practices, such as sequencing admission process steps. Right, so the question, well, back in the day you had to give people a PPD test or a TB test before they could come into treatment. Then it was several days before that could be read. So first they would come in for their first evaluation. We'd say, yeah, you seem like a good candidate for medicine. Come back in a couple of days and into a different office. We'll put that PPD test in. Come back 2 or 3 days after that. We'll read that PPD test. Right? These were all regulatory standards. If it's negative, we'll give you a history and physical, maybe right then or maybe a day or 2 later, and then you can receive your medicine. So some people were coming 5 times before they could actually get medication, right? So ultimately, we just re-sequenced those tests till we created a way to do all of that on the same day without any appointment making. So here's what happened to census. Census goes from around 1,300 in 2006 all the way up to nearly 5,000 people by June of 2018. Right? We did nothing in terms of adding staff at all until July of 2015. Right? Nothing at all, because it was so unnecessary based on the capacity that we had as an organization and the amount of time we were really wasting by no-show appointments. So you have a series of process level changes. Here's wait days to admission. Here is census, right? So basically they're mirror images of each other. Now, again, can I say definitively that this is what caused the growth in census? I can only say that in a temporal way. I know that we were making these changes in this same time period, and this is what happened to census. What I learned from this and what our organization learned was very straightforward. People will actually come to treatment if you let them, right? If you make it easy for them to come to treatment, they'll come to treatment. Right? We have a lot of ideas collectively that people won't come or they're not motivated to come and that sort of thing. And over and over and over, we've learned this. If you can figure out what the barriers are, if you can reduce those demands on people, it actually is a way for people to use the healthcare system. So in the interest of time, I'm just going to skip through here. This was good for clients and good for the App Foundation and good for the community. So when you look at things like the socio-ecological model of making changes, right, those different spheres of influence, as time to treatment declined, more people entered treatment, barriers were systematically addressed and included bundling all services needed for admission and diagnosis on the same visit. This is a promising practice. Right? We did more than 10 change cycles to move toward our aim, but it was really reinforcing for the staff to see that the more they did, the better we did together. The organization did better, right? Certainly the clients did better over time, the community did better over time. Although people who entered were more acutely ill, as measured by a scale called the Basis 24, they gained as much improvement as their less acute peers. In other words, people got more better as we improved access. I'm from the state of Maine, right? So I'm allowed to say that more better is not very proper English, but people got more better as APT improved access to treatment. And as census grew, APT reduced its reliance on grant dollars. This is the other thing that actually happens, right? We haven't talked too much about that, but financing mechanisms such as grants or implementation service programs, they go away over time. Right? In order to really gain sustainability, we have to figure out how to do things as efficiently as possible. So volume becomes a predictor of quality, but volume in an efficient way also becomes a predictor of potential sustainability on the financial sense. So I can tell you that we reduced our reliance on grant dollars from 53% to today that number is less than 5%. So where the money comes from is the patients actually pay. They have insurance, sometimes they'll give us $10, we help them get qualified for particular programs, but at the front door we never ask them for money because that was a barrier to care. Right? So good for clients, good for the App Foundation, good for the community. This is just one example of the NIATEX approach, using the NIATEX tools, and I'm happy to take any questions.
We have one question here.
Hi, thank you so much for your talk. I think a lot of us gained a new insight to what NIATEX does, and it's interesting actually when you say NIAT in Malay, it actually means niat, which is like intention. So it's interesting to see that.
It's really nice. That's great.
So just to ask you, one of the problems I think a lot of Malaysians have is whenever we conduct a program or any sort of assessment or research for that matter, we have issues with sustainability. So I'm wondering if you have come across when you implement or when you conduct your NIATEX thing, and if you have had issues with sustainability, and what have you done to address those issues? Thank you so much.
Yes, that's a really important question. Thank you. As I said, the coaching and facilitation is divided into 3 distinct kind of phases that are happening more or less simultaneously. That's building relationships, building capacity, and building sustainability. So if the changes that you make, this is where the key principle of NIATEX comes into play. Understand and involve the customer. If you make changes that are not oriented toward understanding what the customer needs and wants, they're more difficult to sustain. Right? So being informed by that feedback loop all the time. And customers are also, they're not just the prospective patients or the people living in our communities, they're also our staff. And Sten brought up a couple of points yesterday about how, nurses didn't like this intervention or they were sabotaging this intervention. You really had to figure out why that was true and involve them in the change process as opposed to telling them what to do. So it's this constant feedback loop that I'd love to talk more about, but that's really one of the tricks or keys to sustainability. Good. All set? Thank you.
One more question.
All right, sure.
Hello, Dr. Martins. Thank you very much for the very great lecture we've had today. It's very new, it's very interesting to know and learn about NIATEX. Right, okay, I actually have 2 questions. I'm not sure it's relevant to others, but at least for me. So the NIATEX, as you said, the aims to reduce waiting times, no-shows, increase continuations and increase admission, and I found that NIATEX is mainly has been implemented in a lot of research involving substance use disorders and the key populations such as incarcerated persons, right? Right. So my first question is that is this tool possible to be implemented in other fields? Because the problems of waiting times, no-shows, continuation, admission, these are problems of our general population as well. So I found these toolkits, if I could do it for my general population, it would be very great. But most of the research I found basically they're used in incarcerated persons, right? So that's my first question. So how could I do it using NIATEX for my general population? So that's one. The second one is, well, at least, and probably most of my colleagues we're coming from a conventional, traditional ways of doing research, and we are taught to abide for our protocol submitted to the ethical boards, right? And I found that with NIATEX, implementing NIATEX, it involves the real-time changes throughout your research, right? So is that considered a protocol deviation, like a traditional clinical research, something like that, or is it not? So how do we do that, and how do we tackle that in a way?
Both really great questions.
Thank you.
Yeah, so to the first question, yes, this has been, I gave you a few examples, but this has been and can be a toolkit for implementation in many fields, right? So the basic principles that we really don't necessarily understand, what people need and want, that there are treatment gaps, that processes can really enhance the potential that people will come through the door or that they'll stay in care, that can be applied across many disciplines, and it really has been, right? So this was collected initially for a toolkit for enhancing addiction treatment services, but it has been used in many settings, so including in general medicine. Now your second question, people might give you different answers here, but when you apply to an IRB, what you tell them is what you're going to do, right? So all of this work has passed IRB muster in one version or another. right? It has we have a randomized controlled trial, not called NIATEX 200, where we did NIATEX across 200 organizations. So what stays in the protocol, I think, are the aims of your research questions, and your methods, and this becomes a method. Right? So you heard Dr. Hageman talk about this morning. This becomes a method. There are many research protocols where this has been approved. Now, if you introduce something entirely different, you may need to get an amendment, but we haven't had that situation very often, right? We're using an evidence-based set of tools. We say that the process is going to be iterative, that we're not exactly sure what changes people might make in their organizational processes. And again, so far we have very good traction with IRBs. Thank you all. In the interest of time, I know we're supposed to go to a break. Yeah.
Thank you so much, Professor Lim. Thank you. I think you are Malaysian at heart because we use more better with our Malaysian English as well. So it's very apt. So before we head to a break, we've run over time, but I think we can spare 10 minutes for everyone